Good afternoon, everyone. Today we are doing stone scenarios in our Urology FRCS exam preparation series. Thank you for the trainee who has agreed to record this session so that it will be a good revision source. Your first scenario, time starts now. You have a 25-year-old lady presents with history of left-sided loin pain. How are you going to evaluate?
Okay, so I'll see this patient urgently, take a history, examine the patient, and I'll arrange some tests. In my history, I'll establish the duration of pain, consistency, and the character of the pain. If there's any associated hematuria or fever or recurrent urinary tract infections, I'll ask about previous stone episodes, any family history of stones, if they've had any interventions for stones before. I'll ask about risk factors for recurrent stone formations, such as age at first presentation, note anatomical problems like horseshoe kidney or PUJ obstruction, or indeed any metabolic problems like hyperparathyroidism. I'll document their past medical history, drug history, including anticoagulation status. I will then offer a chaperone and examine this patient, feeling the abdomen and flank for any tenderness. I'll document their observations as well, looking for any fever. And I will also arrange some tests, including urine dip, plus or minus culture, food blood count using his calcium, uric acid levels. And in view of the history of flank pain, I will organize a CT-KUB after documenting a negative pregnancy test for this lady.
Okay. Her urine dipstick shows 1 plus RBC and 3 plus leukocytes, no nitrates. Bloods were normal. Anything you want to do?
So I'll confirm my suspicion of renal colic with the CT-KUB, non-contrast.
Okay. I will share the pictures now.
Thank you.
Okay, can you see now?
Okay, so
this is the CT-KUB you asked for. I will scroll through from top to bottom so that you can dictate as you see.
Okay. So axial CT of the abdomen, scrolling down, there's some fullness on the left kidney with dilated ureter, periureteric stranding, following the left ureter down, which demonstrates some fullness. All the way down to the pelvis. Okay, and there is evidence of a distal ureteric stone on the left side. I will need to measure this to confirm the size, as well as the Hounsfield unit of the stone.
Okay, the size of the stone is 6 millimeter and Hounsfield unit is 950 HU.
Okay, so this is a 6 millimeter distal ureteric stone on the left side. With upstream dilatation. So I will confirm the patient's observations, check their pain status, administer analgesia, and await the results of the food blood count and using these to decide on the best management option moving forward.
Okay, her full blood count using these were normal. And what kind of analgesia you are going to plan for her?
So for this lady, I will give her PR diclofenac, 100 milligrams, as well as paracetamol to try and control her pain.
Okay, if PR diclofenac is not helpful, what is your next choice?
So I will administer some Oromorph, oral opiate, to try and help control her pain as well.
Why PR diclofenac?
Oh, okay, so if PR diclofenac is not available, I could give oral diclofenac or indeed any oral non-steroidal first, after excluding the contraindications of severe asthma or gastric ulcers.
Okay. Why are you planning for PR diclofenac rather than oral? What is the advantage?
So PR diclofenac bypasses the first pass effect, and it's very effective in controlling renal colic pain. But if it's not available, I can also give oral diclofenac.
Okay. Her pain settles down. What is your next steps?
So with control of pain in the absence of a fever and normal bloods, I will discuss management option of this lower ureteric stone with this patient. I'll discuss options including conservative versus primary ureteroscopy versus ureteric stent or nephrostomy. However, my preferred option, if the patient is in agreement, will be to manage this conservatively, as a distal ureteric stone of that size has a high likelihood of passing spontaneously.
Okay, so what is your criteria for selecting a patient for conservative management?
So my criteria will be the stone size, which is 6 millimeters, a distal ureteric stone, normal bloods, absence of any features of infection. So this would all be in favor of conservative management.
Okay, so how are you going to explain this to her?
So I'll explain to the patient that I will need to, we will look at her scalp film to see if this stone is visible, of which if it's visible, I will arrange a follow-up for her in about 2 to 4 weeks' time with an X-ray KUB on arrival to check that the stone has passed. I will advise her that she may feel some pain in this period. She will be discharged with some analgesia. And the safety net and advice would be to return to A&E as quickly as possible if she develops a fever or if her pain is not settling with analgesia. And this would be indications to re-attend hospital. I'll warn her that there's also a chance that the stone doesn't pass when we see her back, in which case we will be advising for an intervention at that point.
Okay, so you are seeing her in 3 to 4 weeks' time, and you are doing an X-ray KUB which shows persistence of stones. She has on and off pain but maintaining well with painkillers.
So I will explain to the patient that at this point, the stone is not passed. I will repeat her bloods to see how her kidney function is doing at this point. But given that 3 to 4 weeks is passed and the stone is still there, I will rediscuss management options, but I will be inclined to offering intervention at this point to try and treat the stone in the form of a primary ureteroscopy or a shock with lithotripsy. Okay.
How will you explain this to her? If you are giving shock wave lithotripsy, what is your protocol?
So I'll explain to her that shock wave lithotripsy, I'll explain the procedure, alternatives, risks, benefits, and I'll aid my counseling with a bowels information leaflet. I'll explain that this involves administering shockwave to fragment the stone, which will then be passed naturally. This is usually covered with analgesia. I'll explain that the risks include infection, bleeding, failure to fragment the stone, risk of fragments being stuck, in which case she will require a further procedure in the form of a ureteroscopy or a stent. But I'll explain to her that there is a high likelihood that this will be successful. The alternatives will be ureteroscopy. And so I'll go through the counseling in this format. and ask her to sign a consent form if she's in agreement.
Okay. So if you're planning for ureteroscopy and on the day when she comes for the surgery, she's signed, consented, prepared, general anesthesia, everything is in place. What is your steps? How are you plan for the surgery?
Okay. So in an appropriately consented anesthetized patient, WHO checklist done.
We'll stop there, Emika. It's time now. Okay. Good.
Thank you.
Good presentation. No concerns. Straightforward scenario. We started very simply. Communication and knowledge and delivering the knowledge all are very optimal level. I'm very happy with that.
Thank you.
Few things which we can need to concentrate is medical expulsive therapy. You haven't highlighted it that much. You haven't brought the tamsulosin. I thought
I haven't actually. Yeah, you're right.
Yeah, that's a very good opportunity to bring you the mimic trial, suspend trial, and a few trials to get the ball rolling. And you know about the recent, not very recent, 2019 NICE guidelines. So I thought you will bring the NICE guidelines at 2-3 places. That will make your presentation from the region of 7 to 8 easily. And the other minor concern is, if you see 2019 NICE guidelines, the painkiller protocol is perrectal diclofenac 100 milligram. We can give even once or twice a day. Usually it's 50 milligram 3 times a day, so you can easily give at least 2 times maybe in a day. And if they are not responding, the second choice is IV paracetamol. And if IV paracetamol is not working, the third choice is the opioids. You haven't brought the IV paracetamol to the picture. You said oral paracetamol. And in the history, you missed the occupational history. We need to make sure that, especially in men, there may be an occupational history of a pilot or a lorry driver, or maybe in the army. And in a woman, again, she may be in the army. So that is important. Urine dipstick, there is no signs of any infection. I think you've done well with that. Pilot CT image is very important. That's what will dictate whether when she comes next time, whether we can depend on the X-ray KUB or not. Read a little bit about the role of ESWL in lower ureteric stone, because it is not very straightforward. Normally we do in supine position for the renal stones. As the stone gets into the lower ureter, patient may need a prone position so that the shock waves nicely reach the VUJ, because VUJ is much more anterior compared to the kidney in the anteroposterior sagittal pictures. And there is also a technique where we can keep the patient supine itself and using a gluteal window. If you are discussing ESWL, which is correct because NICE guideline says ureteric stones up to 10 millimeter ESWL/ureteroscopy, but you should know what is the challenge in doing ESWL for a lower ureteric stone. Okay. You have any questions?
No, thanks. It was the MET was an important one that I missed out. So thanks for pointing that out.
Okay, it happens. Okay, can we go for the next scenario?
Yes, please.
Okay. Your time starts now. A 60-year-old lady presents with history of left-sided loin pain and fever. And the A&E team suspects it's a urosepsis, and you are called for to give your opinion.
So I will consider this a urology emergency, and I'll go see this patient immediately and assess the patient in line with ABC protocol and instigate sepsis 6, taking bloods for cultures, lactates, urine culture, and also giving high flow oxygen, IV fluids, and antibiotics in line with local guidelines. I'll then take a history and examine the patient, establish the duration of pain, and also if she's had any previous known stones, if she's had any interventions for stones before. I'll ask about her past medical history and fitness for surgery, if she's on any anticoagulation. And I'll examine this patient with a chaperone, looking at her observations in A&E. I'll then examine her abdomen, examine the flanks for any tenderness, And following on from this, I would arrange some tests, including urine dip and cultures, bloods, including full blood counts, using his calcium, uric acid levels. And then I will, in view of my concern about an obstructing kidney stone, I'll arrange for an urgent CTKU.
Okay. Regarding CTKUB, is there any different types of CTKUB available?
So there is the low dose CTKUB and the standard CTKUB. Hounsfield unit at the radiation exposure being between 2.5 to 5 millisieverts.
Okay, any criteria you will decide which patient needs low dose and which patient needs high dose?
So for a low dose CT, if the patient is very young, if they're recurrent stone former, or if I'm anticipating that this patient will require lots of CT in the future, then a low dose CT may be a place to start from.
Okay, are you able to see the picture, Shad?
Yes, I can see a scout film, a scout CT film showing the abdomen and pelvis. On the left side, there is an opacity in the left kidney, in keeping with the Staghorn calculus. I can also see a small stone in the right kidney. I need to look at the cross-sectional images to confirm this.
Okay, I will take it from top down.
So indeed, there's a Staghorn stone in the left kidney, and there is a right upper pole stone, a right lower pole stone, sorry. There's no obvious ureteric stone that I can see.
Okay, so what are we going to do?
So, in the presence of a Staghorn stone on the left side, I will explain this diagnosis to the patient. And I missed if that left kidney was obstructed or not. I can't quite recall if there was any hydronephrosis on that left kidney. But I would explain that this to the patient, that there is a Staghorn stone in the left kidney occupying almost the entire pelvic ileus system. And this will likely be responsible for the fever and pain she's having. I will resuscitate her and administer antibiotics to try and treat her sepsis. And definitive management will be planned down the line. But from the emergency perspective, it will be to get on top of her sepsis and control her fevers first.
Okay, how are you going to do that?
So this would involve giving her the sepsis 6 protocol, IV fluid, IV antibiotics, oxygen. After sending urine sample, blood cultures, taking lactates, giving oxygen, and monitoring her urine output.
Okay.
I may need to discuss some microbiology and also look at her previous urine sensitivities to guide my choice of antibiotic treatment.
She had no previous antibiotic sensitivity pattern for her urine. You are sending the urine sample for culture and sensitivity. What is your choice of empirical antibiotic?
So my choice of empirical antibiotic would be a broad spectrum antibiotic in combination with a start dose of gentamicin. So if she's not penicillin allergic, I will give her IV chlormoxiclav and a start dose of gentamicin.
Okay, she is getting improved gradually. What is your plan? After 2 days, she is afebrile for 24 hours.
Okay, so at this point, I will discuss definitive management of her stone with her. I'll explain to her that she has a Staghorn calculus, and I'll explain to her the natural history, which will likely lead to progressive renal failure and complications associated with Staghorn calculus based on the papers or studies that we know from Blandy and Singh, as well as Steigman et al., and a recent meta-analysis by Alsawi et al. So I will be recommending treatment of a Staghorn stone down the line by means of a percutaneous nephrolepectomy.
Okay. So the patient wishes to know more about the procedure. When are you going to plan, and how she needs to prepare for that?
So with the aid of a BOWS specific information leaflet, I will counsel her explaining the risks, benefits of this procedure, explaining alternatives, and what the PCNL entails. The benefit is to treat the Staghorn stone in the left kidney by making a puncture into that kidney and gaining access and fragmenting the stone with energy in the form of ultrasound and lithoclast or pneumatic energy and try to clear the stones. The risks include risks associated with gaining access, which include damage to surrounding structures such as the bowel, spleen, and damage to renal vessels. Risks associated with the procedure, such as damage to the kidney, bleeding, failure to clear the stones in one setting, requirements for nephrostomy, and maybe stents. I would also explain to her the risk of residual fragments, but that this procedure gives her the best chance of clearing the stones on that side. I will mention the alternatives of flexible uteroscopy and shock of lithotripsy. However, this will not be recommended for a Staghorn calculus.
Okay, what are the types of PCNL you are aware of?
So, in terms of position or?
Yeah, both position and the size of sheath possibly.
Okay, so the types of PCNL in terms of access could be the standard PCNS, mini PCNL, ultra, mini PCNL, and micro. And the sizes will depend on the access size. So standard PCNL will be 24 to 30 French. Mini will be, I think, 16 to 18 French. And then ultra mini and micro PCNL will be even lesser sizes in that order. PCNL could also be done prone or supine. And so this will need to be discussed with the patient as well.
So what kind of PCNL you are planning for her?
So I will, given the Staghorn stone and the size of it, I'll be planning for a mini PCNL in a supine position, as that would also grant a retrograde access if necessary at the same time.
Okay, we'll stop there. Good. Another very straightforward scenario. We haven't gone to the depth of PCNL complications follow-up. Maybe as a reflection, you should be able to tailor your answers in the initial stages. Equally, sepsis is important. If there is a small lacunae in presenting the sepsis 6 or any of the components, examiners will stay there to make sure you're safe and you're good in treating the initial emergency presentation. There is no doubt in that. But at the same time, we need to balance one way or another so that you can reach a little bit more. Otherwise, good presentation, whatever you said, you're doing your good. I'm glad that you brought in sepsis 6 protocol. I'm glad you're able to pick that small stone on the right side. When you are consenting for the patient for the left PCNL, it will be nice if you brought in that there is a 4mm, 5mm stone on the right side, which I will advise the patient for conservative management for monitoring, or later we can even treat with ESWL. So keep that in the brackets in your mind.
Okay.
And low dose CT. The indication for low dose CT is BMI less than 30. Any patient with BMI more than 30, we need to give normal CT because of the fatty abdominal apron. Low dose CT will not give the clarity in the stone situation. So BMI you need to bring in less than 30, more than 30 for low dose and high dose CT. Yeah, types of PCNL. If there is a question, no need to ask the examiner whether it's due to the positioning or size. You can just go on, say it is divided into 3 different classifications, one based upon the position, and then go try to bring in the terms like Gladico, modified, Valdavia position, something like that. Because you guys are, I know that you guys are reading all these terms with a lot of difficulty. There is no point. There is no price if you are not
withholding information.
Yeah, if you're not bringing it in the 10 minutes. So you should be able to bring just one term, Gladico modification of Valdavia position, whenever you are saying supine PCNL. That really gives the examiner a good impression. Okay, you are able to bring in the terminologies. Mini PCNL, I will say even up to 20 French. There are some studies which included up to 22 French. So any standard PCNL, 22 to 34 French. Mini PCNL, say 16 to 22 French, and even though 22 is really big. And then try to remember about the ultra mini PCNL and the micro PCNL also. They won't ask much because we are not doing that frequently. And glad that you brought in supine, and I thought of asking some questions like why supine, what is the advantage of supine compared to prone, but by the time the time has run. Yes, supine has its own advantages for the surgeon and also for the anesthetic especially. It saves a lot of time in repositioning, and the position related injuries are much less in supine PCNL. Even though the name is supine, we are really tilting the patient adequate enough to reach the posterior calyx. So in essence, we are still reaching the same posterior calyx. We are not puncturing the anterior calyx. That has to be well understood. And very rarely, say for example, if this patient, I haven't taken you through the scenario of sepsis, you may have saved a minute and a half. So we may be discussing the steps in the PCNL, what is the energy source, etc. Supine PCNL, you should be able to, I mean, especially if it is a mini PCNL, you should be able to bring the energy source of laser also, because it gives excellent vision, and with whirlpool effect, you can clear maximum amount of stones. For this type of Staghorn stone, which is almost a complete Staghorn stone, my preference is supine standard PCNL. Nothing wrong in mini PCNL, but always when you have multiple options, there is something which is the best, and then we have the second and third options, and sometimes we regularly do the second and third option. In practice, I will certainly do a supine mini PCNL, no doubt in that. But in the exam, you can say supine or prone standard PCNL is the ideal one, but I'm aware that people will do even the mini PCNL also. Nothing wrong in it. And you may need another puncture, and nothing wrong in it. With flexible nephroscope, you can avoid some punctures also. Regarding the long-term follow-up of patients treated conservatively, the Staghorn patients, especially the elderly patients treated conservatively, there is one article from Mr. Subramaniam et al. Also, which is also relatively 2015, 2016 recent article. I will try to get that and share it in the
I haven't seen that. Thanks.
Good. Happy to have one more scenario?
Yes, please. Yes, please.
Okay. Your time starts now. A 75-year-old gentleman presents to your clinic with a significant difficulty in passing urine. How are you going to evaluate him?
So I will see him in the clinic, take a history, examine the patient, and arrange some tests. In my history, I will establish duration of the symptom, if there's any associated storage lower tract symptoms, whether there's been any visible hematuria, any urinary tract infections. I will document the past medical history and medication history, and see if it's had any treatments for these urinary symptoms. Following on from these, I'll offer a chaperone and examine the patient, examine the abdomen for a palpable bladder, examine the genitalia, and do a DRE to assess the size of the prostate, and for any abnormalities on the prostate. I will then take some urine for urine dip and cultures, do a flow rate, a post-void scan, get an IPSS score, and after appropriate counseling, I will offer PSA testing.
Okay. His examination showed at least 100 to 150 cc, huge prostate, median sulcus obliterated, no suspicious signs of any nodules or firmness. He's very fit otherwise, not on any medication. IPSS score is 30 out of 35, quality of life 6 out of 6. He's very symptomatic, external genitalia examination normal, and PSA which you have sent came as 1.1.
Okay, so he has a normal PSA, however, a very large prostate and severe low tract symptoms, bothersome low tract symptoms. So I will counsel this patient. My management option will start off with conservative first, establish what sort of fluids he's taking, give conservative advice based on that. Given the size of his prostate, I will commence him on a combination of finasteride and tamsulosin, and then I will reassess it again in 3 months' time to decide if he needs any further intervention.
Okay, you are seeing him in 3 months' time. He has no change in his symptoms. He is still struggling to pass urine, predominant symptoms of strangury and weak stream, and he is taking tamsulosin and finasteride, but no effect.
So at this point, conservative and pharmacological options have failed. I will discuss surgical options with this patient. And given the size of his prostate, the realistic options left for him are holmium laser enucleation of prostate or an open Millings prostatectomy.
Okay, so how are you counseling him?
So I'll counsel him with the aid of a BOWS information leaflet. I'll discuss the risks, benefits, and alternatives of this procedure. I'll explain that the purpose is to clear out the prostate, to open up a channel to allow him to pass urine better. The risks of the procedure include infection, bleeding, persistence of lower uterine symptoms, new onset overactive bladder symptoms, small risk of urine retention, anesthetic risks, risk of clot in the legs, clot in the lungs. And following on from this, I'll discuss the alternatives, which are Millings or a TURP, but I will explain that the preferred option will be the holmium laser enucleation of prostate.
Okay, you are consulting him and preparing him for holmium enucleation, and on cystoscopy you find his urethra is normal, sphincter is nice and working, prostate is huge, trilobar, creating nice obstruction, and on entering the bladder you find a huge bladder stone. What will you do?
So in this case, I will explain to, well, the patient is already anesthetized, I believe. This is in theater?
Yeah.
Okay. So with a huge bladder stone that I can see on x-ray, this is possibly up to a 5 centimeter stone in the bladder. And so this will be difficult to manage endoscopically. And so I will consider I'll consider waking this patient up and discussing options of open cystotomy, stone removal, and Millings prostatectomy at the same time. However, if I have a high power laser with a 550 laser fiber, then I may be able to tackle this endoscopically, but in which case I will only do the stone and wake the patient up and explain the findings and bring the patient back for HOLEP enucleation of prostate down the line. So this would be the two possible approaches to this scenario.
Okay, let us assume that you are aware of this large bladder stone before consenting itself. Will it change your approach?
Yes, this will change my approach because this stone will be best approached by a cystotomy and stone removal, as well as open prostatectomy at the same go. So the benefit is shorter operating time and also achieving the purpose of relieving bladder outflow obstruction as well as treating the stone in one go.
If the patient wishes to have treatment only for the stone and he said, Doctor, I think the stone may be the reason for my symptom, treat the stone and I will take the prostate bit later, what will be your choice?
So my choice will be between endoscopic laser fragmentation, which will take time, or an open cystotomy and removal of stone, and then coming back later for bladder outlet obstruction surgery. So I'll counsel the patient about these two options and make a choice.
Yeah. Is there any method between these two, open cystolithotomy and endoscopic lithotripsy? Any in middle path?
So the using the cystolithopaxy is an option where we can use stone punch. However, the size of the stone, it's very unlikely that you can engage that with the stone punch. The other option is a combination of laser and a stone punch, where if the stone is fragmented to smaller fragments, then a stone punch can be used to break the stone and wash them out.
Okay. Do you aware of any percutaneous approach?
There is a possibility of percutaneous approach where one can then use ultrasound and lithoclast energy to fragment the stone. So this is also an option.
So how will you plan the percutaneous approach?
So this will involve, in an appropriately anesthetized patient, ultrasound guided puncture into the bladder, introduction of a cystoscope or even a nephroscope to allow the use of the Swiss lithoclast master to fragment the stone.
Okay. And what is your exit strategy? You are doing a suprapubic approach and fragmenting the stone, say with lithoclast and nicely fragmented. How are you going to complete this procedure?
So to complete this procedure, I will ensure maximum drainage of the bladder by means of a freeway urethral catheter, as well as a suprapubic catheter. And this will allow irrigation on both sides. And then I'll reassess in the following days post-op. I will then reassess and determine how to remove the catheter if the urine is clear.
If he's getting well, very good in the post-op period, what will you do?
So in the post-op period, I will first of all remove his urethral catheter, leaving the suprapubic catheter in situ, and I may then clamp this suprapubic catheter to see how he gets on passing urine before removing it, if it's indicated.
Okay, good. It's time now. We will stop there. I think you did well. The only thing is you should remember what table you are in. That's very, very important. We have spent a lot of time in prostate, and whenever the scenario comes like that, difficulty in passing urine, generally we think of prostate, and once you evaluate like that, you will entirely get into the prostate treatment. But this is a stone table, and the other possibility is infections, isn't it?
Yeah.
So if it is a stones and infections, even you can tell the examiner that this patient has voiding symptoms predominantly with a huge prostate. So my aim is to evaluate him. But since this is a stone table, I'm keeping the stones as a possible for his problem. The stone could be in the urethra, the stone could be in the bladder. So I will do an X-ray. That's it. It's a very simple one. In real life, you are correct. In real life, what you have said is the only thing happening, and we may end up finding a stone on a later date. But unless if the patient gives history of passing any small stones, etc. But that's why it's important. You should know what table you are in, and no way. See, you have traveled a long distance, almost like 4 to 5 minutes on large prostate management, combination treatment, whole up, everything, isn't it? So if you have the stone table in your mind, you will think about which stone can cause voiding LUT. So it could be urethral, if not bladder. And in real life, if the examiner crosses you, oh, why are you thinking about the stone? You can say, this is a stone table, so I wish to keep stones in my options. Nothing wrong in it. It's very, very practical.
I think it's very useful that you say that, because when I got the question, sort of threw me slightly off balance. I wasn't sure if we had switched stations or if we're still at the stone. But what you say is right. Keeping in mind that this is a stone station, I should have considered a bladder stone as well. So thanks for.
There is another example also. For example, in penile cancer table, penile cancer, testicular cancer, prostate cancer table, patient may present with something like a severe belanoposthitis like presentation, and we may be led to discuss like an infection table, belanoposthitis, STI, ruling out STI, and we may completely track off. But if it is a penile cancer, testicular cancer, prostate cancer table, patient presenting with significant infection with a lesion in the tip of the penis, we have no need to go there. We know it's definitely leading towards penile cancer one way or another. And similarly, if the same scenario comes in the infection table, you will not try to bring in the penile cancer, even though you keep it as one of the differential diagnoses, just to make sure we are not ruling out the penile cancer. And this is a real scenario, bladder cancer, so we should be very confident in that. And you can bring in uroflow. Sometimes uroflow is quite good. You haven't brought in uroflowmetry for a large stone starting on medication. There is no indication for ultrasound unless the patient had any signs of renal failure or deranged renal parameters. But uroflowmetry is indicated even if you're not bringing stone. When you are placing the SPC, not necessarily every time you need ultrasound. The BOWS guidelines on SPC placement states it should be ultrasound or cystoscopy guidance. And since you are there, you can place the SPC track by using the cystoscopy guidance. The puncture can be just like a 3-part or 2-part needle like your renal puncture. Place a guide wire, dilate it, and amp plug sheath. Just like PCNL, you should bring in the amp plug sheath and everything. And regarding stone punch, you are correct. Such a large, smooth stone punch will not get you that initial purchase. But once you use the laser, once you get some rough edges, stone punch has a role. If you want to treat both, as you said, the open cystolithotomy, so that we can remove the stone intact, that will be very, very time saving. And you can go ahead with Millin's prostatectomy. That's the best choice. But at this present stage, with the level of practice people are trying their best to keep endoscopic. So for the stones, the best endoscopic method is through the suprapubic tract compared to transurethral. So you should bring in the suprapubic tract in the discussion. For example, this scenario, your mark will be just 6 because of two reasons. You haven't brought the suprapubic tract cystolithotomy on your own. And the second thing, we have spent a lot of time not thinking
talking about
the stone.
BPH.
On BPH. Not bad. Getting 6 in once in a while is okay. But if you're a little bit careful, this is a very good scenario to again touch 7.5 because there is no hard questions to that, isn't it? So remember the suprapubic approach for a large bladder stone. That's the main take home.
Thank you.
Good.
Thank you.
Any other questions on any of the 3 scenarios which we discussed today?
No, I think you've given very good feedback. This last one particularly is good because you can have this thrown in, and the starting question may veer you off the table, and it's just keeping that in mind and staying focused on the table. So thanks. That's very useful.
Yeah, I think what I will advise is try to have kind of a very small notebook. If it is like a A4 size paper, I will say for every table, just only 2 sides of one A4 size paper. That is enough. And talk twice taking notes. For example, first scenario, you have missed medical expulsive therapy. That whole scenario may be a medical expulsive therapy table or scenario. And I'm very sure you have discussed medical expulsive therapy not only with me, with few others in the past. So this happens because as you read more, sometimes you are quite overwhelmed with the amount of facts you have, and that logical bringing out may slightly jeopardized. So have one A4 paper, maybe 2 sides, or even 2 A4 paper, maximum only 3 sides of an A4 paper, and have notes, stone scenarios, ureteric stone, medical expulsive therapy, just in the brackets, suspend trial, mimic trial, just very short notes, not in detail. And unfortunately, there is not much gap between the tables in the present format, but it gives you a good idea to have a quick revision. What is the half-life of HCG? What is the half-life of alpha fetoprotein? So what is the normal value? So those things, just a quick glance before you enter the table. Okay, good.
Thank you.
Good. So if you have no other concerns or questions, we will have another session in next 24 to 48 hours. Okay?
So I'll see you tomorrow. Thank you.
Bye.
Bye-bye.